Hi everyone, thanks for tuning in today. I'm Dr. Emma Pollon-Macleod, Naturopathic doctor, and today with me I have Grace Meehan, one of our pharmacists and NAMS practitioner. That stands for North American Menopause Society practitioner. Right. So super knowledgeable in the field of menopause, so that's why I wanted to pull her into this video so we could talk about the follow-up to the case blog that I just posted earlier on in the week. So we had talked about a case that I had, 49-year-old woman, Katherine, who was coming in for problems with sleep, mood, problems with gaining weight around the middle. I chose this case because it's a good representation of what I see really often.
So common.
Yeah, really, really common. Sleep problems arise, fairly early on. I find like women will report that they've been sleeping well, and then it's the frequent waking up, 2-3 in the morning, mind racing, not sleeping well. Then they're restless they're restless all night, not feeling rested and refreshed in the morning. It's starting to really impact their mood. They're not working out as much because they're sleep deprived, and then they're gaining weight in the middle. So it's kind of this snowball effect that we see really often. And when women are going to see their physicians, a lot of the time the solution that's presented to them is sleeping pills. So
sleeping pills or antidepressants.
Yes, exactly. So, there is an alternative, and that's what we're here to talk about. So based on that, if you go read the blog, so what we had recommended, we did the initial intake, we decided to do a comprehensive blood panel, and we did an anti-inflammatory diet for 30 days. So today I want to discuss our follow-up. So this would have been about 3 to 4 weeks into the diet and after I had the results for the blood work. So on her blood work findings, let's talk about hormones first because that's really important. So in perimenopause, we do measure hormone levels as a baseline. Yes, they are going to fluctuate. Yes, we know that. A lot of people will say, what is the purpose in testing? Because there is such fluctuations. So the reason we test is so that we do get a baseline and I get a sense of how much estrogen a woman is still releasing. So for Katherine, it hadn't been a full year since she hadn't had a period. So she had a period, I think I wrote about 6 months prior, and then before that it was 3 months. So it's starting to become quite irregular. But again, understanding if there are surges in estrogen at that point will guide me to know if it's appropriate to give estrogen or not. And so for this case, when I looked at her blood work, her FSH was in the 50s. Her estradiol was she was still making a little bit, so it was around 95. So she was still, her ovaries are still releasing some estrogen, and her progesterone was at 0. Again, this is quite common. So it's telling me there's still a little hormone release from the ovaries, and giving estrogen at this point might not be the best idea. So what we've decided to discuss today is the use of progesterone for her. So she's not making any progesterone, she's making a little estrogen. Sometimes that imbalance in perimenopause, and you see this quite often when progesterone levels start to really dip and they stay low, and then you have this estrogen that is surging and dipping and surging and dipping, and it really can impact mood, body temperature, that sort of thing. And you see that.
Absolutely. And it's in perimenopause really that women will say that they feel their worst and they feel better postmenopausally when things become more stable. So it's kind of like a crazy time, and women wonder what's happened to them.
Yeah, exactly. And when we talk about hormones, we really are, when we're talking about hormone replacement, we really are talking about two, progesterone and estrogen for women. So with Katherine, I guess I'll get into the hormones now because that's what we're interested in. Then we'll go through the rest of the blood work. So because her hormones were really low, her sleep was super disrupted. She's really stressed out in the evening. She's anxious. We decided to give her a little bit of progesterone, and she's going to take it in the evening. So Grace, let's talk a little bit about that. So I started her on a really low dose because, especially with hormones, and because we like to use compounding pharmacies, we get to dose very uniquely based on a woman's needs. So we don't need to give tons of hormone if we don't have to. Sometimes it just takes a little bit to get that calming sensation, and really help kind of regulate mood and
right.
sleep.
And we've seen this clinically. So progesterone, and we're talking about good micronized progesterone, very, very different than what was used years ago in women, which was synthetic. But micronized progesterone is very calming. Now there's a commercially available micronized progesterone, which is a great product, but it's in a bit of a higher strength. And we found that some women just don't need that much. So, starting them off at 25 milligram and letting them titrate up to their sweet spot really, really works well.
Mm-hmm. Yeah, and when we say micronized progesterone, that means bioidentical progesterone. Mm-hmm. So it's the same progesterone that your ovaries are releasing. So then we can actually measure it as well.
And it's very calming. Mm-hmm. Progesterone is the hormone that dips first in perimenopause. That's the one that goes down. And that's when sleep becomes a problem and women report feeling irritable and anxious because progesterone calms the body. It's really necessary to keep us feeling calm.
Exactly. And the nice thing about and when we're talking about progesterone as well, progesterone is the precursor to making your stress hormones. So when there's a lot of stress, you're running on an empty tank, your body is running on a lot of cortisol, stress hormones. So you will actually utilize more of your progesterone to start making these stress hormones. So it's another decline in progesterone. And this day and age when we're just kind of pushing ourselves through, not sleeping, we're just draining the tank of progesterone. So we're losing that nice balance between estrogen and progesterone that a woman needs to kind of feel calm and confident and regulated
and sleep.
Yeah. So let's talk about the safety of progesterone in this case, because that's a big question, and this is a big reason why I wanted Grace and NAMS Pharmacist in on this conversation, because the controversy with hormones is around the safety, and a lot of women are very skeptical or nervous because of what they've heard or because of what their friends or physicians are telling them. So let's talk about what kind of you say to your patients around progesterone, and then I'll kind of talk about what I say.
Well, so progesterone, micronized progesterone, is so very, very different than the synthetic that was used in the WHI study, the HER study, many studies. So the synthetic was the one that was really implicated in causing issues in women, meaning increased number of breast cancer cases, increased heart disease, etc. It was synthetic progesterone that was used back then. So micronized progesterone being what our bodies, what our ovaries make, there's a lot of safety information out there concerning it. It's never ever, micronized progesterone has never been implicated in a health risk in women. Having said that, if you are in perimenopause and there might be some fibroids growing, sometimes progesterone can help the growth of a fibroid, but that's something that your clinician would take into consideration.
Yeah, of course. And we do practice with an abundance of caution. So, not everybody is a candidate for hormones. And, what I haven't really discussed is Katherine's family history was clear. There is no family history of hormone-positive cancers or a personal history of hormone-positive cancers. She's in a good weight range. She's a non-smoker. She exercises. So there is a lot working in her favor as well. Another one of the risks kind of that I like to say, especially, early 40s when we start to use progesterone, is when ovulation is really sporadic. It's very hard to tell your cycle, and we start to give progesterone, which is a bit of a fertility enhancing hormone. We like to say just use extra caution, and that's kind of the other risk. Use extra surprises. No surprises. So we're giving her a little bit of progesterone. We're having a safety discussion. We're talking about, we will, even though we're not giving estrogen, even when we start bringing in progesterone, I do like to talk about monitoring methods, looking at breast health, talking about mammograms.
Because that is women's health,
yes.
In midlife.
Exactly.
That's all important.
Exactly. And so we shouldn't be afraid to talk about these things, to be afraid to scare women off of hormones, but we should be educating people on their breast health, their uterus health, giving a little bit of progesterone when you don't have any and you're still producing estrogen is protective of the endometrium.
And the breast, actually.
Yeah.
When you have high levels of estrogen and low levels of progesterone, that's when you can get more density in the breast, and breast density is a risk factor for breast cancer.
So it's a nice, we actually think it can be really helpful and protective if you're starting to just stimulate your uterus with estrogen. You don't have any progesterone. You might notice a little bit of more of a bleed when you first start. That's okay, because you're helping to shed that lining. And so that's why it's nice to have a pharmacist you can talk to about hormones like Grace, who's so knowledgeable. So we did a little bit of progesterone. So we're going to start at 25 milligrams, very nice and low, taken at bedtime. And then when we went through the rest of her blood work, we saw that her vitamin D was really, really low. So it was at 50. So ideally, we want vitamin D levels to be around 120. And then especially for women's health, bone density is a really, really big thing as you're transitioning through perimenopause. Estrogen is very protective of the bones. It promotes bone formation and bone strength. So when those levels start to decline, you lose that. And that's why women are more at risk for osteoporosis than men. So bringing in some vitamin D, strengthening up the bones, the immune system, it's really, really essential. So for her, we're dosing her around 3,000 units per day, just to maintain those
and not to mention that D is very important for our mental health as well.
Oh yes, for sure. Yeah, mood, mental health, stability. So it's really essential. We also saw that her B12 was quite low, so it was in the 200. So I actually ended up giving her a B12 shot because it was so low. She was eating animal protein, but often when a B12 is that low and someone's eating animal protein, it's telling me their gut's a little inflamed and it's not absorbing nutrients. And fat soluble vitamin D is low as well. So we really wanted to work on gut health with her. So we gave her a B12 shot. Following up on the anti-inflammatory diet, she actually noticed an improvement in her anxiety and mood and energy just from the diet alone, before we even did any hormones or anything at all. So that was really, really, really eye-opening for her, because we hadn't done anything and it was just diet.
We see this all the time.
All the time.
Yeah.
It's so interesting. And it's empowering for women to kind of, as your hormones change, the way you respond to different foods changes. It's just like sometimes with alcohol, your tolerance changes as you age. Same with sugar and processed foods. What you used to be able to consume, you might not be able to consume anymore, but you don't even notice that that's what's kind of triggering that really sluggishness, low mood, fogginess. So that's really where diet comes into play majorly. Yeah.
It's not as simple as just taking a hormone. It's so much more than that. And when you do target the gut, everything gets better, and the hormones can be just a little, adjunct to it to get women over the top where they're feeling really good.
Yeah, that's what we like to say. We call the hormones the sprinkles on top, right?
The sprinkles on top.
They're not the base layer. You have to bake the nice foundation. Then you do the icing on top, which is the other nutritional supplements. So your diet is the base. You have vitamin D, your B vitamins. We gave her magnesium as well, nice and calming in the evening, great for mood stability as well. Gave her some B12, and then just a little sprinkle of hormones on top to help really regulate and balance everything. That's really kind of the way that we go about doing it.
Yeah.
So for Katherine, the last thing that we did for her, so we gave her magnesium in the evening, 200 milligrams before bed, really nice and calming. It's a really simple protocol that we did for her, but we just really wanted to see what some slight tweaks would do for mood. And then we go from there. We peel back layers. What's improved, what's gotten better, what hasn't. And then we keep working together to make sure we're getting her into that optimal area where she feels really good, rested, energized, mood is coming back. And often this is all it takes.
Yeah.
It doesn't need to be this crazy, huge, complicated treatment. And then, the last thing I wanted to talk about, Grace, was she had also mentioned, and it's funny, this happens a lot, it's not on the intake, it's not on the chief concerns, it's not really anywhere on the intake, but I always like to ask about libido, vaginal dryness, sensation down there. Like some women don't really find the word dryness clicks with them, more of a discomfort or a lack of sensation down there. And that can be because your estrogen levels have been declining, and estrogen is what allows the vaginal tissue to retain moisture and elasticity. So sometimes women experience pain with intercourse, that sort of thing. And so Katherine was starting to notice quite a bit of dryness, discomfort, and pain with intercourse. So much so that she didn't want to engage in intercourse with her partner anymore. So we gave her a really nice low dose of vaginal estriol cream.
Yes. So important, because this symptom is so prevalent amongst perimenopausal and postmenopausal women. In fact, a recent study in NAMS showed that it's causative for depression and anxiety at midlife in women. It's so important, and it's undertreated. And women forget to mention it to their practitioners, or they think it's just, oh, well, that's what happens. But when we treat this, it restores the vaginal tissue back to how it should be, and gets women back their sex lives, their relationship with their partners. And there's a great window of opportunity to treat women with this.
Yeah.
So like you're saying, if you start women with some low dose vaginal estrogen, late perimenopause into postmenopause, it's easy to treat this tissue. But if you wait, it gets worse and worse and worse and worse. And it's harder to get somebody in their 60s and 70s back to normal. That tissue is so fragile and irritated. So yeah, it's a kind of a slam dunk when it's done properly and at the right time.
Exactly. And often, we give ultra low dose. I like to give a 0.1% estriol, so not estradiol, estriol, which is a more gentle form. I like to pair it with hyaluronic acid, which is a moisturizer in itself. Often women, for Katherine, what I would tell her is expect almost immediate relief within the first 2 weeks. So you use it 2 weeks every night, and then thereafter, like once, twice a week.
Yeah.
And often that's all it takes. And some women, maybe will use it once a week, twice a week, here and there. They'll forget sometimes, and then they'll use it again. But all it is just making sure that we're getting a little bit of consistent estrogen in the area, and it can make a world of a difference. And I'm sure some of you listening are you might be a little confused, being, thinking to yourself, wait, you just said not to give estrogen to this woman. Why are we talking about vaginal estrogen? So when we talk about vaginal estrogen, the doses are extraordinarily low. So we're using it as a very localized treatment. It is just to treat the vaginal tissue. It is not a hormone replacement therapy.
Right. So they're not going to do anything for hot flashes.
No. And so this is a very different conversation. There's a whole bunch of research for low dose estrogen therapy or estrogen therapy vaginally. And this is in Canadian medical guidelines. So it's really not controversial. It doesn't fall into the hormone replacement therapy category, but I like to use a cream. So the commercially available one is a tablet. And it's a tablet that you insert. And some women like it, but I find for a case like this with Katherine, and it's bioidentical as well, so we're talking all bioidentical. In a case like Katherine's, we do like to start with a cream because we can actually get some moisturizing other compounds in it. And then you can, again, titrate up your dose, so you're not having to insert a tablet into potentially really uncomfortable area. So that could cause more damage.
And you can take a little bit of the cream and apply it over the labia too, which can be dry and irritated with the. So creams have a good advantage over tablets.
Exactly, because you can start a little bit more externally and work your way internally, and that's often the way that we tell women to start using it. And again, that's often how we get the best results. So thank you so much for tuning in. Thank you so much, Grace, for doing this video with me. I really appreciate it. If you haven't read the blog, you can go ahead and read it. Otherwise, have a lovely day, and thanks for tuning in.
Take care.